Welcome to the Spring 2021 Core Facility Seminar Series. Today we will be featuring the Center for Human Health and Performance, CH2P. I am Lisa Korbieski, the Director of Communications and Marketing here at the Institute for Applied Life Sciences. In today's seminar, Mike Busa, the Director of CH2P, will tell you about the world-class resources available to facilitate basic and translational research in physiological, biomechanical, and behavioral mechanisms of human health and performance. In addition, our guest speaker is Nader Naghavi from Embr Labs and a visiting scientist here in the Kinesiology department at UMass. We hope that with these bi-weekly seminars, you will discover what great resources that the centralized UMass Amherst core facilities offer to our campus community, the New England region, and beyond. And next, just a few housekeeping items. The seminar is being recorded, as you just heard. If you miss any part of this seminar or would like to forward it to someone who could not attend, there will be a replay of this and all previous seminars in this series on our website, and I will put a link in the chat. I recommend you set your view mode to speaker. Please stay muted during the talks. We'll save the Q&A until the end of the presentation. During that time, I welcome you to unmute yourself and ask questions. So now I would like to introduce you to Andrew Bernard, the Director of our centralized UMass Amherst core facilities. Andrew?
Thank you, Lisa. Good afternoon, everyone. Thank you for joining us today for the 7th seminar of the Spring 21 Core Facilities Seminar Series. As Lisa mentioned, my name is Andrew Bernard, and I'm the Director of Centralized Core Facilities here at UMass Amherst. Our state-of-the-art labs, instrumentation, equipment, and world-class experts are helping researchers drive discovery and pursue scientific endeavors across all disciplines. Core facilities are open to anyone from students through senior scientists, regardless of your affiliation, including researchers from other academic institutions and commercial operations. To help access our cores, there are several funding opportunities. For IELTS investigators, core credits and center seed funding is available. For our external users, the Mass Innovation Voucher Program subsidizes usage for small companies based in Massachusetts up to 75%. To date, the program has awarded more than 600 vouchers, representing more than $5 million in project work for our cores. We aim to be your partner by expanding your research capabilities and productivity. Feel free to reach out to me or to any of the core facility directors if you have questions or would like more information about our capabilities and how we might work together. It's now my pleasure to introduce Dr. Michael Busa, Director of the Center for Human Health and Performance, or as I'm trying to force, CHIPS. Mike received his PhD in biomechanics and motor control here at UMass Amherst, and then completed 2 postdocs focused on biomechanics and physical activity. He then joined the core facility team as the founding director of CHIPS. All of this after a career as a professional cyclist. I think he may have joined us thinking it would be a less hazardous career, but I'm afraid to ask him and hear what his answer would be. Mike's been an asset to the core facility team. He regularly provides support on building infrastructure that benefits all of our cores, and he helps me quite a bit on things related to human subjects. We're grateful that Mike contributes to the team, and we're looking forward to hearing more about the core today. So with that, I'll turn it over to Mike and be here and available during the Q&A if you have any questions. Thanks, Mike.
Thank you, Andrew. Thank you, everybody, for attending the seminar. It's exciting to see everybody's virtual faces in my Brady Bunch type screen that I see. To give you a little bit of background on what CH2P, or as Andrew's, as he rightly says, he's trying to get us to be called CHIPS. I'm resisting somewhat. We have 4 research themes formally within CHIPS. So we have the exercise intervention and outcomes area, human motion, living science, and then we have our room calorimeter, or metabolic chamber. We're co-located with the sleep monitoring core. The core facilities are available to both on and off campus users. We can train anybody that would like to be to use any of our instrumentation. We have consolidated billing across all 4 of our themes, which makes it pretty, whoops, let's see here. Sorry about that. Makes it straightforward for those who are navigating budgets for grants. Once we have users that are approved, everything is self-service with scheduling and billing occurring through our quorum system. If you are looking at putting together a grant application, feel free to reach out for consultation on budgeting. I also can provide letters of support for projects that we use the facility. And a good reminder is that we're in close proximity to the other human subjects cores, sleep, Health, and the HMRC. And we have had many projects over the last few years utilize multiple of those cores in one study visit. So the convenience is there. CH2P offers a whole range of testing. We do everything from some mechanical testing, laboratory testing. We have a couple simulated living environments. And with the goal of really trying to take a lot of the devices that are validated and developed in our facility out into the real world. And we have a host of capabilities for doing some real world testing. So we don't exist only with just me. So we have a nice team of research staff that are working on providing services in a bunch of different areas. So it's myself, Katie Colfer, who's been our longest standing tech. She's also serves as our operations coordinator. Ramsey Majaj is our biomechanics technician. Miriam Searles is our participant recruitment specialist. Nick Hathaway is a project manager. And Stu Chipkin also assists as our consulting physician. So with that, it's my distinct pleasure to introduce Nader Naghavi who has a joint position with Embr Labs and the UMass Kinesiology department, as Lisa said. Nader received his PhD in 2020 from the University of Tennessee in mechanical engineering under the direction of Eric Wade. He applied a variety of machine and deep learning techniques to human motion signals, did a lot of work on class imbalance problems. He joined Embr Labs in late 2020 as a senior physiological data scientist with a co-appointment in the Department of Kinesiology here. His day-to-day right now is he works with myself and my group on a grant that is looking at developing new closed loop digital therapeutics and is our algorithm specialist on that project. So with that, I'll hand it over to Nader, and he'll walk you through some of the work that he's done over the last several years. Thanks.
Thank you, Mike. Hi, everyone. This is my pleasure being here. So through the following slides, I'm going to talk about some examples of artificial intelligence and wearable technologies that can improve the quality of life for different groups of patients or whoever needs those type of technologies. First, I will briefly give you an introduction of my background and what brought me here. Then I will talk about the study that we conducted at the University of Tennessee on developing external queuing technologies for patients with Parkinson's disease. And then finally, I will talk about the project that Embr Labs and UMass are working together on developing automated cooling devices to mitigate hot flashes in menopausal women. So as Mike mentioned, I received my bachelor's and master's degrees in my home country, Iran. I received my PhD from the University of Tennessee in December 2020. And since I finished my master's studies, I've been working in different areas of academia and industry. So I've been working on rehabilitation, robotic devices, and then I joined a research group as a control system engineer to develop control systems for wind turbines and hybrid turbines. And then I started my PhD right after that. And then from the late December 2020, I joined Embr Labs and UMass to start working on this very exciting project. So the first project, as I mentioned, is called an automated external queuing for patients with Parkinson's disease. I'm going to give you a bit introduction on Parkinson's disease and this specific symptom that we were working on, which was called freezing of gait. And then we can see how queuing therapy, which is a form of non-pharmaceutical therapy, can improve this symptom. And then I will talk about the technology that we developed over the course of a 3-year. So PD is known as the second most common neurodegenerative disease. It is characterized by motor and non-motor symptoms. Motor symptoms include tremor, slowness of movement, hastening of gait, reduced arm swing, poor balance, stability, and different other things. And non-motor symptoms may include cognitive impairment, hallucination, and depression. PD is also known as the most common disorder leading to gait disturbances and falls. So as you can imagine, it is also associated with increased dependency and emotional stresses and overall reduced quality of life. 900,000 patients were diagnosed with Parkinson in 2020, and it is estimated that within 10 years, 300,000 more patients are going to be added to those numbers. And that emphasizes the necessity of developing technologies. So now let's see what is freezing of gait. I found this video online. Just hope that we can play it. I promise I was able to play it. Okay, seems like something is wrong. Okay, I have to demonstrate what is freezing of gait. With normal walking, people can just move their feet off the ground and take the next steps. But when freezing happens, they start shuffling. So they cannot move their feet off the ground. And I just wish we can see this video. When they're not able to move their feet normally off the ground, they're likely to fall, and that would cause hip injuries and knee injuries for the patients. So there are definitely some pharmaceutical treatments like levodopa and dopamine agonists, but they are mostly effective in earliest stages of the disease, and their positive effects wear off over the time, like 2 hours to 4 hours after taking their medication. The positive effects wear off, and we call that period off medication, and they need to take their next dose. Levodopa also is known to be inducing dyskinesia, which is erratic involuntary movements in upper body. So researchers and clinicians have started to develop new technologies called external cues. External cueing can be administered in 3 forms of visual, auditory, or somatosensory, or called haptic cues. With visual cues, we can show the patients where they are supposed to take the next step, and we can basically bypass the damaged basal ganglia and supplementary motor areas, and we can improve their gait characteristics. With auditory and haptic cues as temporal cues, we can show the patients when they are supposed to take their next step. So it is basically something like the sound of a metronome, like, and with that, we are able to override the internal rhythm of the gait, and then we can improve the cadence and other gait parameters. External cues can be provided in 2 forms of always on or on-demand cues. With always on, we can provide cues repeatedly and over the time, but that may cause adaptation because we are frequently overwriting the internal rhythm of the gait in each individual. But with on-demand, we require additional systems to first identify the freezing of gait episodes, and then as soon as we identify them, we can provide the cues. And when I say identify, I mean a combination of detection and prediction. Detection refers to the time when the fog happens, and then we identify it and then trigger the stimuli. And prediction means we identify the symptom ahead of the time, like 1 second or 2 seconds prior to the onset of the symptom. And then we provide preemptive cues. And with that, we might be able to prevent the symptom from happening. Pathfinder is a commercially available device that works in always on cue mode. And that basically generates laser lines on the floor. The other product that I'm really fascinated by is the Google Glass project. So when they turn on the LED on the Google Glass, they can see a lady walking in front of them, and they can basically set the speed of this lady, and then they can synchronize their steps with this virtual lady. This is a very brief literature review on how freezing of gait detection and prediction have been working on. So it started in 2010, maybe sometime sooner than that, but Bachelin et al. Used 2 IMUs on the shank of the participants, and then they noticed that if they extract a feature in frequency domain, they can see that the feature values increase as soon as freezing happens, and that was a non-learning method. So they basically just use a threshold to identify freezing from non-freezing. But since then, other machine learning-based methods have been used to improve the sensitivity and specificity of the classifiers. So as you can see here, with the study conducted by Zia, they achieved almost 100% sensitivity and specificity. So those are great numbers, but I will talk about them, why they are not being used widely. The same for fog prediction. It can be predicted based on the literature, but with the cost of lower specificity, as you can see in different studies. So with those results, we defined 3 objectives for our study. One was to improve the fog prediction rate. The second one was to design an automated on-demand queuing device. So we were trying to use wearable sensors, and we wanted to develop a mobile application that can identify freezing in real time. And then finally, we wanted to evaluate the effectiveness of this system in an ambulatory environment. And that's basically because fog happens much more frequently in the participant's home than in a clinical environment. So we started recruiting participants. We ended up with 21 participants. We asked them to wear 2 IMUs on each ankle. This is just to show you how small those IMUs are compared to a human wrist. We asked them to walk in a narrow hallway. We had a narrow turn and a wide turn areas at the ends, and a very narrow walking space in the middle. And we were just basically trying to trigger as many freezing episodes as possible, because at the end, we were trying to distinguish freezing from non-freezing. And the more freezing episodes we had, the more sensitivity we could get eventually. So we collected data with accelerometers, and from the 2 axes of front and vertical accelerations, we extracted these 4 features. I'm going to skip talking about these features, but if you have any questions, you're welcome to ask the questions at the end of these slides. This figure shows how the raw data and how the extracted features can show us the occurrence of the symptom. So the blue lines are the raw signals from forward acceleration and vertical directions. The gray areas are the freezing episodes that we identified with the cameras. And then the green boxes are 2 seconds pre-FOG. The red lines are one of the features that we extracted from the raw data. So as you can see, the feature values start to increase within the pre-FOG area in some cases, and in some cases within the FOG area. So they can represent happening of the symptoms. Just this specific features freeze index. One major or one fundamental issue that we had with this data set was that from our 21 participants, only 7 of them froze during the data collections. And with other 14 participants, because we didn't have their freezing data, we just had to exclude them from our classification problem. The other problem was that with those 7 participants, with the 3 of them, as I highlighted, the ratio of the fog class is so low, even below 15%. That means that our models would be biased towards the classification of non-freezing class. So that was one issue. We expected to see lower sensitivity with the models and high specificities. So to address this issue, we tried 3 standard techniques in machine learning. we compared the results from individual classifiers like SVM, KNN, and multi-layer perceptron with those achieved with ensemble classifiers. As you may know, ensemble classifiers just combine results from a group of weaker classifiers and merge them together to get a higher performance. The other method that we used was adaptive synthetic or Addisine oversampling. With that, we artificially created new samples of our minority class or the FOC class. So we're able to improve the balance between the two classes by artificially creating samples. And finally, we also investigated the effect of cost-sensitive classification. With that, we used higher penalty for misclassification of our minority class. So with these three methods, we were able to improve our sensitivity in the models. The other thing that we investigated was how patient-dependent and patient-independent models can work. So with patient-dependent, we use the data from the same participants to train and test the classifiers. And with patient independent, we implemented a leave one out cross-validation, which means that we trained the models with data from 6 participants and then tested this model on a new participant. So we expected to receive better performance on patient dependent, and we did. So I'm just going to talk about patient dependent models. The random forest classifier trained with Addisine showed the overall highest accuracy. We achieved sensitivity of slightly above 90% and a specificity of 95.5. The other thing that we were interested to know was how many of the freezing episodes we are actually able to identify. And our results showed that 67 of the freezing onsets were identified within 2 seconds prior to the FOG onset. 31% of the rest were identified within 4 seconds after the symptom. So overall, 98% of them were identified, again, 2 seconds prior to 4 seconds after the occurrence of the symptom. So we improved the prediction rates compared to the literature, but we had 2 major issues. One was we had to exclude 14 participants. One solution was that to use patient independent models for them. So we trained the models with data from other participants and then tested it on these new participants, but they just showed poor performance. So that was not a reasonable solution. The other issue is that because we wanted to implement this algorithm into a real-time application, our estimation showed that with a specificity of 95, we would end up with 25 false alarms per 5 minutes. That means every 5 minutes, we trigger the cues 27 times while the patient is not frozen. So that's not so different from the always on cues. So with the, in future, we wanted to improve these 2 metrics. And we actually wanted to know how we can use anomaly detection methods to improve the sensitivity and specificity of the models. This is a 2D visualization of the data. So as you can see, the normal gait samples of all those 7 participants are clustered and they are distinguishable from each other. Each of them are clustered in different areas of this 2D space. And the freezing of gait samples are just randomly scattered into this space. And that suggested us that we can use anomaly detection methods in this problem. Anomaly detection algorithms enable us to take advantage of this imbalance in our data set. So when we have a larger portion of the data from our normal class, we can better characterize our normal class. And then everything beyond those characteristics can be identified as anomalies, or in our case, can be identified as freezings. the state-of-the-art anomaly detection methods are deep anomaly detections. So with these neural networks, we can not only map from a high dimensional space to a lower dimensional space, but we can also map all the normal classes within a closed space. And then everything from the anomaly class can be mapped outside this circle. And then we can just use a simple classifier to distinguish anomalies from the normal class. So we wanted to take advantage of this approach, and we trained and tested a convolutional neural network. So with this network, we're not extracting features from our raw data. We wanted our model to take care of feature extraction. So the input for this model was the raw data, acceleration and weight gyro from 2 seconds of the data. We input the raw data into the model, and we wanted our output to be something like this, like the output had only 2 neurons, and we wanted all the normal gait samples to be clustered within this circle, and all the freezing of gait data within a separate circle. So that was the goal, but when we trained the model, we noticed that we are getting something more like this, that all the samples are mapped aligned with this line, crossing the 2 centers of the 2 circles, and the normal gait samples are mapped within the circle, and everything beyond that are freezing of gait. As I mentioned before, we had 2 goals with this approach: improve the specificity and see how we can use data from other groups of participants to train a model for a participant who didn't freeze during the test. So the answer to the second question was to use transfer learning. So we trained a reference model with both classes of the data from those 6 participants. And then we retrained this model to create a model that was called target model. And for retraining, we simulated the condition that we don't have the freezing of gait data for this new target participant. So we retrained only with normal gait data. And because we didn't know how many episodes we have to train the model, we used a specificity threshold, and we used a separate validation set for that. So after each epoch, we fixed the networks. Those boxes shows that the layers are fixed. We classified the validation sets, and we calculated the specificity of the model. And if that was above a threshold, we stopped the training at that epoch. If it was not, we continued until we reached that specificity of the model. And finally, we tested the model with both classes of normal gait and freezing, and we calculated the sensitivity, specificity, and the prediction rate. This is the ROC curve for our model. We could get higher sensitivities and specificities, but we wanted to have, if we could go with higher specificities, but with the cost of lower sensitivities. But we decided to take this point as our working point. So with this, we were able to predict almost 22% of the episodes within 1 second before the occurrence of the symptom. And the total identification rate was 87%. So with this deep anomaly detection algorithm, we were able to address those 2 fundamental issues. The state-of-the-art method, if they don't have the data from the freezing of gait data from a new participant, they just have to use patient-independent models. And as I mentioned before, they show very poor sensitivity and specificity. So this table compares our model with the patient-independent models in the other studies. We also were able to improve the specificity of the models. The average specificity of 98.6 means that with these models, we expect to receive something slightly above 8 false alarms per 5 minutes. And that's like 1/3 of the false alarm rates that we had before. And finally, we wanted to see how this system may work in a real-time application. So we asked the participant to wear these two IMUs in their homes. We developed this Android application, implemented this deep neural network into the application so we could analyze the data in real time on the mobile device. And then we also paired a smartwatch with the mobile phone. So every time that the phone detects a freezing, the watch triggers haptic and auditory cues for the patients. And they can select if they want the haptic cues or if they want the auditory cues. Unfortunately, because of the complications of the COVID, we only were able to recruit 4 participants for this final step of our study. 4 patients used the system for 6 weeks in their homes. We used Gait and Fall questionnaire to measure the effectiveness of our intervention. And for these 4 participants, we noticed an overall reduction in Gait and Fall questionnaire, which means that their gaits were improved and they were less likely to fall after using 6 weeks of this device in their homes. We also asked them to fill a usability questionnaire, and they gave us many good comments about the sensors and the mobile app, like they desired a change in the sensors and sensor bands, because it turned out that wearing 2 sensors early in the morning for patients who have tremors is not as easy as we expected. And they also suggested a change in the user interface of the mobile app, which was expected. We published our results in IEEE, TNSRE, and sensors, and we submitted the results to IEEE JBHI. And we also presented some of our results in different conferences. Okay, and now we are going to talk about the study that we are conducting at UMass with the collaboration with Embr Labs. So this study is called Automated Cooling to Mitigate Hot Flashes. In the following slides, we will briefly talk about what is hot flash, what are the current treatments for hot flash in women, how we can identify hot flashes using wearable devices, and how we can activate automated cooling. So hot flashes are defined as transient episodes of flushing, sweating, and sensation of heat, often accompanied by palpitation and feeling of anxiety, and sometimes follows by chills. What that means? It means that women feel like they're hot, and then they start sweat, and because they sweat and because of the evaporation, most of the time they feel chill after the hot flashes. And as you can see in the graph on the right, which listed the main menopausal systems, hot flashes are the most common complaint symptoms. About 65% of women complain about having these hot flashes during their menopausal periods. Each episode of hot flash may last between 3 to 10 minutes, and typically the symptoms last between 6 months to 2 years. But women who started flushing before the menopause, studies have shown that these categories of women may experience longer durations, about 11 years, compared to the other women. Who may experience hot flashes? Women of premenopausal, postmenopausal, and women with breast cancer are likely to experience hot flashes in their lives. About 75% of women are estimated to experience hot flashes, and which means that in the United States, about 50 million women are suffering from hot flashes each year. And how hot flashes can impact the quality of life. Hot flashes can negatively affect sleep, and they can cause mood disturbances. They can also cause physical, social, cognitive, and emotional decline for women. There are some treatments, hormonal treatments for hot flashes like estrogen and progesterone. But the studies have shown that these hormonal replacement therapies can be associated with increased risk of heart disease, breast cancer, and stroke. And certain group of women, like breast cancer survivors, are contraindicated from using these type of medications. Also, vitamin E has been administered. Cognitive behavioral strategies have been used to reduce the severity of hot flashes. But not only these methods or these treatments have not been as effective as they should be, but also they are based on subjective hot flash measures, which means that they ask the participants to fill some type of questionnaires to express their hot flash severity and frequency. But as we know, they are subject to cultural backgrounds, like certain women with certain cultural backgrounds are less likely to talk about their symptoms. The other thing is that during sleep hours, women are less likely to report their hot flashes. So that's another issue, and that emphasizes the necessity of having an objective method to identify hot flashes. There are some recommendations by North American Menopause Society to improve the symptoms, like avoid warm rooms, hot drinks, caffeine, alcoholic beverages, use cooling products like sprays or cooling pillows, try different strategies to stay cool while sleeping, like dress light, cool down with a fan, keep frozen cold packs of or bags of frozen peas under your pillow. So they may work, but I don't think that a large portion of women are going to do this type of methods. The other thing that is recommended is if you wake up at night, just drink some cool water. So different companies have started developing different devices to help women cool down when they feel hot flashes. Cool Cough and Embr Wave are two types of bracelet that you wear on your wrists, and they locally cool down your wrists. Menopod is the other company. The technology might be the same, but the thing is that you can put this device on different locations of the body wherever you feel the hot flash. In this study, we're going to talk about Embr Wave. This is the device that we're going to use. We just launched the second generation of Embr Wave last week, so this is very new. Check the website. I'm sure you will be impressed. How Embr Wave works, it has a thermoelectric heat pump that transfers heat away or towards the skin on the wrist. So the thermal sensation is felt through a ceramic plate, which is right underneath the device. And with that, we can have cooling and warming sessions within different modes, from a quick 3-minute session to all night, which is an 8-hour session. The only difference between the cooling and warming is the hot flash mode that provides 10 minutes of continuous cooling through the ceramics, through the device. Embr Lab technology have been validated through different studies. I'm not going to talk about them. I just wanted to highlight the key results from those studies. Like the first study conducted by the University of Berkeley showed that when the participants wear this Embr Wave device, it takes less time for them to fall asleep again if they feel a hot flash or if they wake up for any other reason. And it also decreased the sleep onset latency, which is the time from going to bed to falling asleep. So based on these, we wanted to develop a non-hormonal, non-invasive treatment to address these hot flash symptom in menopausal women. And the end goal is to just design a closed loop technology that automatically identifies hot flashes and then provides cooling session for the users. And that's where Embr Labs and UMass joined together. UMass is working on developing the technology to identify the hot flashes, to develop objective measures for hot flash. And Embr Wave is the device that we will use for the intervention or for the cooling sessions. Studies have been, researchers have been using different technologies and different data channels to identify hot flashes. One of the most widely used devices are called biolog, and they are skin conductance sensors. They measure the skin conductance or skin resistance, and based on that, they identify the occurrence of hot flash symptoms. So this is one example. This is not from our study. This is from one of the studies in the literature. This is the skin conductance data. So as you can see, right after the occurrence of the symptom, there's a spike, and that's about 8 units of the skin conductance. So those type of spikes in the data can show us the occurrence of hot flashes. The other data channels that have been used to identify are skin temperature and core body temperature. So as you can see, there are some sort of similar patterns of increasing temperature in both skin and core body temperatures. And then as soon as the hot flash happens, the temperature goes down, probably because of the evaporation on the skin. Other studies have also investigated the heart rate and respiration rate. And as you can see, after a few seconds, after a few seconds of hot flash onset, heart rate and respiration rate typically increase, but as you can see, in a very short period of time, it goes back to the normal. But for other data channels, we can see that it takes a few minutes to get back to the baseline. This is a very short literature review for hot flash detection. I try to only include the most important ones. I think it started in 1999 when Carpenter and their group used the biolog devices to identify hot flashes. They reached very poor sensitivity and specificity, and their method was basically just thresholding the data. If the skin conductance is above the threshold for a period of time like 30 seconds, that is a hot flash. If not, it's not a hot flash. And that's their approach for detection of hot flashes. Later, 10 years later, Thorsen and their group used SVM classifiers to identify hot flashes in laboratory and 2 years later in ambulatory environments. And their sensitivity and specificity are comparable in both environments. And in a later study in 2018, Fourzanfar et al. Used the same method as Carpenter, but they optimized their method. So they had some filters on their input and outputs, so they were able to improve the sensitivity and specificity of hot flash detection. So based on these results from the literature, we have two objectives for this study at UMass. We want to improve the state of the art and see if we can actually predict hot flashes before the symptom occurrence. And then finally, we want to close the loop with Embr Wave to see how we can improve the symptoms. And that means the severity of the symptoms and the frequency of the symptoms. To collect the data from participants, we are collecting data from multiple channels on their body. We're collecting actigraphy on wrist, we're collecting EDA on chest and lateral torso. We are collecting heart rate and heart rate variabilities. And we also have one extra channel from the biolog, and we ask the participant to put this electrode on the location that they mostly feel hot flashes on their body. So it could be on their chest, it could be on their back, on their neck, or it could be on their shoulder, different locations on the body. And we also ask them to mark or to log their hot flashes, and they are provided with this note so they can paper log, or they can, or one of these sensors have a button on this so they can digitally mark their hot flashes. These are just some examples that we collected from our participants in this study. This is electrodermal activity or skin conductance, so we can see the same pattern of spikes in the data. This is the skin temperature. Again, we can see skin temperature spikes right before the hot flashes, and also the heart rate. We can see some patterns of heart rate probably in this data as well. Sorry. Okay, so for this study, we aim to recruit 50 participants with daily hot flashes. Each participant will undergo 4 48-hour visits. The first visit is only actigraphy. We just collect their motion data. Visit 2 and 4 include all monitors and also the hot flash markers for sure. And we expect that by the end of this data collection, we would have the largest data set on hot flashes, and we want to make this data set publicly available at the end of the study. We see some challenges for this study. One is we still rely on subjective reports to train our models. But one issue is that not all hot flashes are very well perceived by the participants. Some of them are perceived but are not reported. For example, they might be driving, they might be sleeping, and some of them may not be reported at the same time that the hot flash happened. So we have to be careful about those events. The other issue might be that we have seen similar patterns of hot flashes with physical activities. So one major issue would be for us to identify those events and make sure that not physical activities are not classified as hot flashes. And the same as a previous study with freezing of gait, hot flashes are rare during the days. So they may happen 7 to 10 times probably. So we need to push our models to higher specificities. So that's one main objective for us in this study. And finally, I wanted to thank a great team of researchers and co-workers at Embr Labs and UMass. Thank you all. We have been all working together with data collection, with brainstorming of this idea, and we still have a lot to do. Finally, some references that I have been referring to in my slides. And now, if you have any questions, I would like to hopefully answer all of them.
Excellent job, thank you. We do have a few questions that we received prior, but I'll remind folks, if you have questions, please feel free to either put them in the chat and we'll read them for you, or unmute. And feel free to ask yourself. The first question is, can your sensors predict when a hot flash is about to happen? That's one thing that we set as one of our objectives. So we want to see if we can identify hot flashes before their occurrence. We don't know yet, but we hope that we can do. Next one is, what are the disadvantages of such technology? Pretty broad. So can you be more specific about disadvantages? I can talk about the challenges, but I'm not sure if that would answer the question. So that's the specific question. So maybe some of the challenges would be ideal. It might help folks think about what you're working through. Okay, so the challenges, as I mentioned, are with the
ground truths for our model training. Again, not all of them might be reported. Some of them might be not aligned with the occurrence of the hot flashes. One other thing is that the pattern of the signals for physical activities are similar to those of the hot flash. So we need to make sure that our models are able to distinguish these two classes. And then finally, we don't want to trigger cooling sessions repeatedly during the day. So we have to be careful about our false positive rates because hot flashes are rare and they just happen very rarely during the days. So those are the challenges that we have seen so far. There might be more.
I'm muted. Sorry that. If you happen to have submitted one of those questions and you want more information, please feel free to unmute. But otherwise, anybody in the audience have a question?
There's a question in the chat from Catherine Ellis. Can this technology cross over to other health wearable devices like Apple devices?
Well, that depends. So we have different data channels, and we don't know which of them are actually useful for accurate detection of the hot flashes. But if they are able to implement those sensors, probably they can also use take advantage of this type of models that we are working on. But eventually, yes, we hope that we can create a very small device that can collect the data, and then we can identify hot flashes objectively.
Okay, we have another one. You said that one challenge is that hot flashes may not be perceived or felt. That makes me wonder, how exactly do you formally define a hot flash in that case? Is it a spike in core temperature?
Oops, sorry. So we are not looking at those type of things. That is one challenge because we will have less labeled data with hot flashes. We're not dealing with those. We are not manually labeling those events just because we think there are hot flashes. But this could be one challenge because from the notes that the participants fill, this is a very repeated thing that we see. I'm not sure if it was a hot flash or it was just a feeling hot episode. So we are looking at those episodes, but if the participants marked them as hot flash, we treat them as hot flash. If they don't, we just mark them as not hot flash. But I was just trying to say that if they are all accurately marked, we expect to get a better performance model at the end. But if there are hot flashes but labeled as non-hot flash or the opposite, that may just reduce the final performance of our models. I just hope that was answering your question.
Well, we have another follow-up question. How well can a patient distinguish false positive cooling sessions from successful preemptive cooling sessions? Is it possible that they couldn't tell the difference?
Probably yes, but at the end of the day, they can they can compare the frequency and the severity of their hot flashes. Like before using the device, they had 10 hot flashes a day, 7 of them were very severe, 2 were mild. But after a while, they are using this device, like a month of using this device. The frequency is reduced to only 4 or 5, and the severity is much less. So we can tell that the device have been actually helping them.
Thank you. Any additional questions for Nader or for Mike? Okay. Well, then I want to thank everyone for attending today's seminar, and a special thank you to Nader. Our next seminar is scheduled for Tuesday, May 4th, featuring the Human Magnetic Resonance Center, HMRC. This facility provides state-of-the-art non-invasive neuroimaging, whole body imaging, and spectroscopy technologies for academic and industry-based research. It also houses the only research-dedicated 3T MRI system in Western Massachusetts. So save the date, and we hope to see you there. Goodbye, everyone.
Thank you.